So how do we treat migraine? We start out with well, it depends on the patient, but let's say they come to me, most typical is they come to me with a chronic migraine. And we start off with working on their preventive treatments. So we target a medication, and the indication for medications are typically if you're having more than 4 headaches a month. I rarely see a patient who's having less than 4 headaches a month, so I usually go right to medication. And then we work hard on their trigger management to the extent that I can, right? And I'm not a psychologist. I can't get into a lot of stuff with them, but I go over schedule and I go over the routine and I reinforce that again and again and again. But then we also do turn to our psychologists to help us work on behavioral therapies. And some of our patients are interested in complementary alternative medications also, and we're certainly happy to help support that. Less data for that than behavioral therapies, and we'll talk about that. And then we talk about abortive treatments, and we make sure that they have a good regimen of abortive treatments. Abortive treatments are triptans, usually. Triptans are things like Imitrex, Relpac, Zomig. It's a whole family of medications that have been developed to be and shown to be exceptionally helpful for migraines. We try to stay away from opiates. We try to stay away from compound analgesics like Fioricet, Fiorinol, and Midrin. And we don't, this is a little bit a short category. We don't have a lot of great tools for migraine other than triptans and ergotamines. And then we focus with them on relieving factors. Sometimes a migraineur will tell you that getting to sleep is the best thing that they can do. So we work on trying to help them sleep if that's what it takes to reset their brain. Frequently, migraineurs will go to bed, wake up, and they'll feel better. But it's just getting to bed when they're in so much pain can be really challenging, so we'll help with that. And then sometimes we do interventions like Botox for chronic migraine. And sometimes we do extreme treatments. What I mean by that is just bringing them into the hospital, giving them IV medications, trying to break the chronic cycle and transform it back to episodic. But the one I want to focus on right now is just the behavioral therapies, because I think that's probably what you guys are more interested in. We can certainly go back and talk about any of these at any time. So where I think that that behavioral treatments can make the biggest impact are in helping my patients manage stress or relaxation from stress. And I don't, I haven't ever worked in other parts of the country, but I do work in Silicon Valley, and I see my share of patients who have stress. I don't think I have any patient who comes in zenned out in bliss. They all have very stressful lives. The way I've learned about stress in relation to migraine is, the way I think about it, is as an allostatic process. So it's a process that is involved in maintaining human homeostasis and necessary, but it's managed through change. And we all have our baseline allostatic load, our burden of stress, but at points in time, we can have an allostatic overload. And the result of that chronic stress, our poor adaptation to repeated stressors, our inability to shut off or tone down this allostatic response once the stressor is terminated, can lead to pathologic consequences. And that can be complicated by poor sleep, poor diet, poor exercise, and alcohol and drugs. Drummond and Pachier in The Headaches, which is a book which is kind of like the Bible for headache doctors, talk about the role of stress in headaches. And it can actually impact the headache at every stage. So it can impact, stress can impact your development of headaches to begin with. So you may have an underlying genetic vulnerability to migraine, but you may never have a migraine until you get into a very, very stressful situation. It can precipitate and exacerbate each individual episode. It can exacerbate the progression. By progression, I mean transformation from episodic migraine to chronic migraine. It can worsen headache-related disability and quality of life, and the actual headache experience can become a stressor that can impact your health and well-being. I'm going to talk a little bit about that in a slide or two. So just to kind of frame this is a little bit how I think about this. I see a lot of people who come into my clinic looking like this. They are unhappy, they are stressed out, they are physically frowning, they are aggravating their frontalis and their corrugator and their procerus. Their shoulders are hunched up like this. They are causing a lot of pericranial muscle tension and tenderness, which can aggravate nociceptors, nerve cells, which are innervating those muscles, and lead to, especially if you're a migraineur and have a little bit of increased vascular reactivity, this can lead to a perivascular inflammatory state that can be sustained from repetition. And so even though, and then you see what we call peripheral sensitization. So you see this increased nociceptive response. So when you have one, very basic way of thinking about peripheral nociceptive responses is that one nociceptor is firing, and if that nociceptor doesn't shut off and it has other influences that are inflaming it, more nociceptors will start to fire, and pretty soon you have a regional nociceptive stimulation. That goes to the spinal cord, which goes up to the brain, which leads to central sensitization. So, oops, wrong right here. So at the central level, stress is very much a cause of hormone release along the hypothalamus and pituitary and adrenal axis. So we have all the hormonal modulation that's going on, but then we have this nociceptive response that's going up to the trigeminal nucleus, leading to increased excitability at the brainstem and triggering migraines and undermining whatever inherent ability we have to turn that volume down. So everybody has a baseline different ability. Most of us have a normal ability, but migraineurs, their ability to turn that volume down is a lot lower. And with all this incoming sensitization, all this incoming signal, it just overwhelms their system and they can't turn it off. So I think about this picture as kind of trying to manage the triggers. I can't really do much about the genes yet, but I can try to help her manage her triggers. And stress is a big one for her and for a lot of our patients. This was just some interesting, there's been a lot of discussion about sympathetic tone, and do migraineurs have higher kind of baseline sympathetic state than other people? And that has never really been proven before in the medical literature, but more recently, this group, Gass and Glaros, were looking at heart rate variability differently than has previously been examined before. And they showed that some different markers of heart rate variability were abnormal in migraineurs, implying increased sympathetic tone. It supports our hypothesis, but we'll see if we see more papers heading in this direction and measuring autonomic dysregulation in pain patients and in headache patients in general. But these patients being constantly in pain seem to run a little higher in terms of their sympathetic state, and you have probably all noticed that when you're managing these patients. And the other way that stress plays a role is in this conditioning response. So this is maybe a little bit unique to migraine and not to chronic pain. A migraineur is told by their doctors, take your medications early, take your medications before the headache hits, just when you start to feel it. Well, that's fine if you have one headache a month. If you have a headache every day and your insurance company only gives you 10 triptans a month and your doctor's telling you if you take more than 10 triptans a month, you're going to get into medication overuse headache, you get into this, you develop a lot of anxiety and fear about when the headache is going to hit and how you're going to treat it. And that becomes a very scary cycle for a lot of people. So a lot of people will just start pre-medicating, and maybe they can't get 10 triptans, but they'll take whatever they can get. And when the headache doesn't mount to its full force, that will reinforce their beliefs of the necessity of taking medications. And then they'll get into this cycle of early and frequent med use, which leads to medication overuse headache. And this is a really hard cycle to break because I'll admit, doctors are very much responsible for this. We want them to take their medication early, but we have to do a lot of discussion about the proper use of the medication, and if all we're giving them is medication as a way of coping with their pain and managing their pain, they frequently get into this situation. So they need other tools. The headache management skills that have the most data behind them are these ones on top. CBT, stress management, coping skills, biofeedback, and relaxation training. There is not much literature on mind and body treatment for migraine. The kind of guru on these therapies and studying them for migraine is Kenneth Holroyd, and in 1990, these studies have been done way back since the 70s, but an early meta-analysis, 1990, looked at 25 trials of patients with a preventive, propranolol, basic preventive, versus 35 studies of patients receiving relaxation and biofeedback, and both showed a 43% reduction in the migraine index. That's the migraine index is the number of headache days per month. That's how we kind of rate headache, and only 14% in the placebo group. So typically in the pain literature, we see about 30% with just any treatment. So the placebo is a little low, but these were a lot of studies, and this was a good meta-analysis. And medications and therapy were both higher than our average placebo in pain. A more recent, I'm skipping ahead a little bit time-wise, but this is a study about biofeedback, meta-analysis looking at biofeedback for tension headache. And tension headache, sorry I didn't define it earlier, is just head pain without any of the features. So they do not have the photophobia, nausea, vomiting. It doesn't seem like their pain is as severe, and it typically doesn't last as long. But again, you see pretty dramatic 37 to 50% reduction in headache frequency and only 2% for the wait list controls. Pretty impressive study. This is a meta-analysis of randomized controlled trials. And what's really nice is that these benefits are stable for 17 months of follow-up. I mean, we don't see that in any medication in the pain world. You know, the studies aren't done that long. They're done for 3 months or something like that. But 17 months is really quite a long time. Holroyd went in 2001, took 200 patients, randomized them to 4 groups with a tricyclic, placebo, tricyclic plus stress management therapy. And this was a program that their group developed. They've since changed their program a little bit, and we're going to talk about their program in the end. Now they call it behavioral management therapy because it's not just focusing on stress. It's more incorporating kind of all of the lifestyle factors that we have talked about earlier. By 6 months, all groups had statistically significant improvement compared to placebo, but the group that received tricyclic, which is amitriptyline or nortriptyline, very common medication for migraines, plus stress management therapy, 64% of those patients had, again, a greater than 50% reduction in the headache index. And so that's that's a very typical way that we measure patients. We want to know that they've decreased their monthly headache burden by more than 50%. That means we're doing well. TCA alone had 38%. Just stress management therapy alone had 35%, and placebo came in the lowest at 29%. So in 1999, these government agency reviewed all of the literature. 355 studies, found 39 of them meeting criteria for inclusion, and came up with the following recommendations. Relaxation training, thermal biofeedback, and CBT were more effective than waitlist controls. Active treatments had about 32 to 49% reduction in headache frequency versus 5% for waitlist controls. I mean, in my opinion, it's very solid data, and the U.S. Headache Consortium guidelines agreed. So the U.S. Headache Consortium developed guidelines for how all headaches should be managed, and they gave grade A support, or they thought there was grade A evidence for relaxation training, for thermal biofeedback with relaxation, for electromyographic feedback, and for cognitive behavioral therapy. At the time, this was this was the early 2000, I believe, 2001. They thought there was grade B evidence for behavioral treatments. And behavioral treatments has kind of been like a smorgasbord of whatever the group wanted to do. Behavioral treatments combined with preventive drug treatments. So more recently, Holroyd and developed a more specific behavioral management therapy plan. And they did a study with 200 migraineurs after 5 weeks, 5-week period of optimal med management. So basically they're just getting their abortive regimen squared away. Then they put them on a preventive, and they randomized them to a beta blocker, placebo, a beta blocker plus behavioral management, placebo plus behavioral management. And all groups improved, but the beta blocker plus behavioral management had a statistically significant change after optimization at 10 months, and then again, long follow-up, 16 months. And when you look at the study, if we look at the yellow line on the bottom, you can see that these patients are decreasing their migraine days by about 6 days a month, which is very significant, and that they continue to get improvement. And as the therapy continues and as they continue to follow them. So they have this migraine management period right here, and then they have the evaluation period. And in the evaluation period, they actually do some kind of troubleshooting to see if the patient's on track with the behavioral migraine management protocol. But I think this is really excellent data and comparable, if not better to, certainly better than what we're seeing with medication alone. So their management program was I really like, and I just want to go over it quickly because I think it is kind of a model of what could be done in 4 weeks. The week one is a group session, week one, and I'm sorry these slides aren't in here, you guys, so I can certainly email them to Dr. Prasad, and he can, if anybody wants or can email me, I'll send you the new slide set. So week number one, they go over the pathophysiology of migraine. They highlight the relevance of behavioral migraine management skills. And so they're introducing relaxation, they're including muscle stretching and deep breathing and progressive muscle relaxation and relaxation imagery. They're emphasizing the correct performance of the progressive muscle relaxation. And then week two, they go over they go over individual development of a strategy for managing migraine triggers. So even though you're in a group, you break up and they work with every person, look at their triggers, try to figure out a personal strategy for how you can manage your triggers, and using your what your early warning signs are, your premonitory signs, as a cue to use your relaxation, your trigger management, and where indicated your acute drugs. So they're really kind of working individually on week two, and every week has kind of homework assignments associated with it as well. Week three, they're given 3 options. They can either continue with the basic class, go back to work on migraine management skills, or they can introduce some cognitive CBT stress management techniques if stress is a salient trigger, or they can introduce biofeedback. And they said just the hand warming training. I think they gave everybody a portable digital thermal biofeedback device for home use in this study. So that might not be, realistic, but that was how they set that up. And the way they decided this was basically if stress was a trigger, CBT; if stress was not a trigger, but thermal biofeedback. And then week 4 was to go back over problems and using your skills. So again, specific questions: how did you use your skills? What problems are you having? Everybody actually developed a written migraine management plan, so they wrote it down so that they could refer to it when they are having a migraine. And then they covered relapse prevention, which I thought was really key, especially for migraine overuse patients. So what are you going to do when you get in a situation where you are using your medications 30 days a month again? How are we going to cope with that? How are we going to prevent that from happening? And then after that, Oh, and then I think they gave them some common problems, like an FAQ on common problems that can happen when you're trying to use these skills over the long run and things to avoid. And then they did 3 monthly phone calls after the first month. So they did the first month, and then next month you got a phone call, and the following month, 3 months of phone calls to one-on-one to identify and solve problems and identify and correct any drug adherence problems also. So that was, that's just a very effective, fairly simple behavioral management treatment that doesn't have any side effects like all the medications that we give our patients, and seem to be very effective for these treatments. And I think that this is probably going to be the model that's going to be used for migraine management groups throughout the country. When we look at CAM, complementary alternative medicine, not that much literature on that. And there's Rossi et al. Had a study in 2005 in cephalgia, which looked at 481 patients, and 89% of them reported using a CAM treatment. So, it's a lot easier to go to an acupuncturist for an hour than to sign up for a weekly CBT class. And a lot of migraineurs will spend a lot of money at the chiropractor before they realize that that's just not doing what they need to work through some major issues. But nevertheless, people are using them, and so there's kind of been a push to really evaluate them a little bit more rigorously and try to determine if there's any evidence behind them. And the best study I've seen is this John et al. In the Dr. Kane's group, and they looked at yoga therapy for the treatment of migraine, a randomized controlled trial. And they looked at 72 patients randomized to yoga versus self-care, so just doing what you're normally doing. And then they measured a lot of variables, headache frequency, severity, generalized pain, both the McGill, which is, measures several different components of pain, and then they measured anxiety and depression and medication use. And it was significant. These patients had significant decrease in their intensity, their frequency, their pain, their affective pain rating index, their total pain rating index. Those are the components of the McGill. Anxiety and depression scores, and their symptomatic medication use scores. So it's pretty dramatic improvement with yoga. So I think that that's probably going to be studied a little bit more. I know Dr. Kong talked to you about acupuncture today. I looked for some migraine and acupuncture studies. I haven't seen any, good maybe Dr. Kong shared with you the problems with randomization and double-blindedness in acupuncture, but I haven't seen any good studies focusing on acupuncture and migraine as of yet. Maybe I can convince Dr. Kong to do that. So how do all these modalities work? Well, I think we touched a little bit on that today, and you guys have probably spent years studying that, but we think these treatments work. These cognitive behavioral treatments and behavioral treatments work by decreasing anxiety and depression, by improving self-efficacy and coping, and improving your locus of control. They probably work by decreasing your stress hormones and decreasing the way your hypothalamic pituitary adrenal axis works. And so, we can think about it as modulating the HPA axis, or maybe modulating your sympathetic tone, taking these patients that run high and teaching them some tools to decrease their sympathetic system that's always on. And it may help modify central sensitization, so it seems like it does help give patients the tools to try to turn the volume down. It may also activate endogenous analgesic processes, similar to how and it may be a placebo, but we think more and more that even what placebo is doing is activating endogenous analgesic processes. So much more study needs to be done to understand how it works on the brain, but it is definitely working. It's contributing to our care of these patients. In terms of my patients, it's absolutely essential, and we, that's why we have a very large pain psychology program at Stanford, because we send a lot of patients to our pain psychology team to help us co-manage them, essentially.